Thank you, and thank you for this opportunity. Hi, everyone. My name is Emeka Abakasanga. I'm a research associate at Loughborough University. So we're working on a project Decode, which is sponsored by the NIHR. So today I'll just be giving a brief just introduction of a couple of outcomes that we've had from our study on identification of clusters of multiple long-term conditions and the equitable prediction of length of hospital stay for adults with learning disabilities. So just a brief introduction of the cohort of study. We're looking at learning disability in the UK. So for statistics, there's about 1.1 million adults with learning disabilities in UK, and 54,000 out of them are from Wales, 956,000 of those adults from England, and 31,000 from Northern Ireland. So we observed that the median age of death for patients in this cohort is about 63 years, which is very low compared to the general statistics of life expectancy in the UK, which is around 80 to 83 years. We try to look at the reasons for this. One of the major observations for adults with learning disabilities is about 98% of those adults have multiple long-term conditions. And on an average, 11 multiple long-term conditions per person. So this can be linked to a lot of reasons. Most of them, like I mentioned, is the long-term conditions. There could be other health conditions, including mental health problems, epilepsy, problems with underweight, and there's also issues with, based on the barriers with this population, there's often delay in tracking diagnosis for those patients. So considering the concept of avoidable death, MenCap defines avoidable deaths as deaths that are preventable by good and quality healthcare. So in 2023, about 38% of deaths for learning disabled patients were from avoidable causes, which is compared to 9% for the general population. This has increased drastically in 2023. So from a study by LEDA, the number has increased from 38% to 42% for learning disabled patients, and it's distributed. So the probability of those avoidable deaths is distributed based on the different levels of severity of learning disability. So it's high, 39% for mild learning disability, 32% for moderate, 26% for severe, 3% for profound learning disabilities. And a lot of reasons are to play in this, a lot of administrative factors in hospitals, inaccessible transport, communications, misdiagnosis, and also that just leads to, here is just a little statistics we have from the SAIL database. We observed the mortality demographics for patients within SAIL with learning disabilities. And we observed, again, the highest rate of mortality is around the age group of 60 to 69 years. And that's for both male and females as well. We also observed that the mortality increases with deprivation. So this can be linked with a lot of factors, which could be access to healthcare. Sometimes education can be, there's a lot of factors that could hinder this, that could hinder the quality of life for patients in this group. So this just leads to this is one of the concepts we are trying to address in DECODE. So DECODE stands for data-driven machine learning, aided stratification, and management of multiple long-term conditions in adults with learning disabilities. This work, we try to use the EHR data of patients. We're using SAIL data as well as CPRD to address certain concerns with adults in this cohort. So today I'll be giving presentations from our findings with the SAIL cohort. So just a little about the data set preparation. For the inclusion and extraction criterion, we've considered adults with learning disabilities. So we try to find out adults that have a code linked with learning disabilities. Based on the scope of this project, which is looking at adults, we take out individuals that are 18 years and alive within the study start date, which is January 2000, and are resident in Wales, and also registered to a GP. So following this, we also have collaborations with the Professional Advisory Board made up of clinicians from the NHS, which helps to identify some major conditions with adults with learning disabilities. So initially, we had about 110 conditions. So we had a couple of meetings to merge certain conditions. Some conditions were also removed. And again, like I think someone had mentioned initially about identifying what condition is long-term or will be the basis. So there are some conditions that it's clearly a long-term condition. So once a patient has this, we understand that the patient can have this for a very long time. But there are some other conditions that are not, that could be acute, but we have to define a couple of decision criteria for defining those conditions as long-term. This was with collaboration with the PAP. Then for the data cleaning and harmonization, we made use of a lot of data from SAIL, which is the WLGP data, the inpatient data. We also took into consideration demographic information, as well as the death statistics to look at the mortality distribution for this patient. After that has been done, we considered a couple of outcomes. So I'll just be giving a few results that we have found from the other, amongst the different studies that we are doing with this data. So the first outcome we addressed was analyzing hospitalization to check severity of certain conditions amongst patients with learning disabilities. We also try to look at models to predict hospital durations for unique admissions with this patient based on different information for every individual. We looked at clustering of long-term conditions of patients with learning disabilities. So for the first with analyzing, we looked at the demographic distribution, also try to address commonly treated conditions in hospitals for patients with learning disabilities, and also looked at the primary conditions as well. And at the end of the day, we also looked at looking at the distribution of some of those conditions for adults with learning disabilities. Two major conditions is mental illness and epilepsy. And most of these conditions lead to long-term stays in hospital. So we try to address most of the statistics as well for long stays. So in the first, with the hospitalization data, looking at 2000 to 2021, there were about 4,000 male patients with distribution of admissions of about 32,000. So it's possible to have one patient with multiple hospital admissions within this duration of study. For the female, is a bit lower with admission rates, which is 4,600 admissions and 4,600 patients and 29,000 admissions. Again, the hospitalization rate also increases with deprivation index. This is the Welsh index of multiple deprivation that we looked at. With the age distribution as well, both look similar and normally distributed. We also observed a huge drop in the number of admissions after the age of 60 to 69 years. So this again is linked with other existing research about the life expectancy, where it's about 60. The average life expectancy is about 64 years for men, 67 for female. So after this age group, so around 70, it drops down, and there's very little admissions of patients above 80 years. Looking at the comorbidity, that's the number of long-term conditions with age. We see a linear progression as well for both male and female. So that's just what this chart shows in initial results. So again, look, we consider the common and primary long-term conditions treated between 2011 and 2021. So for the primary conditions, the SAIL database is a PEDW database, which is of the patient episode data of hospitalizations. So there's the variable of diagnosis number, which ranks the different conditions or different ICD codes based on the number one represents a primary condition for which the patient was admitted, and the other secondary conditions were also ranked as well. So for the primary conditions treated, cancer is the top for both male and female, followed by epilepsy, chronic pneumonia, chronic airway diseases, and mental illness. So like I said initially, chronic airway disease is a group of, this is one condition that we grouped a couple of conditions, asthma, bronchiolitis, and the rest of them. So for common conditions, we're considering both primary and secondary conditions. The top for both male and female is epilepsy. For the males, it's followed by diabetes, chronic airway diseases, mental illness, and cancer. For the female, the epilepsy followed by chronic airway diseases, diabetes, thyroid disorders, and mental illness. We looked at the distribution of hospital stays, and we tried to observe the box plot and look at the upper whiskers and that referring to the outliers. So we had a boundary of 129 days from the box plot analysis, and we looked at the conditions that were linked to admissions lasting longer than 129 days. Mental illness was the top, about 900 admissions in this data, and 61% were treated for mental illness. We looked at the age distribution. We observed that, so for patients that do not have mental illness, most of those patients were skewed older. So those conditions were more linked to old age, like the diabetes, dementia, cerebral palsy. Although it's possible to have some patients with some of these conditions at early age, but majority of the data, the patients were much older compared to patients with just mental illness. So we also looked at a couple of findings, from news outlets for just this year. There's a lot of information about hospitalization, and so there were two extremes, cases where patients were prematurely discharged, which led to about 2,000 readmissions for just this year within a month. So after patients were discharged within a month, they had to come back to the hospital. Another extreme is about patients who have been stuck in hospitals. So the distribution from what we found in SIL, we found patients staying as long as more than 5,000 days in the hospital. Most of those admissions were linked to patients who stay in long-term mental health facilities. But again, we understand there's a campaign by NHS to try to reduce the length of stay. Just some few statistics about this. For 2023, 5,000 people were readmitted in mental health facility within a month of living. The University of Birmingham also considered another study where they looked at 2,000 patients with learning disabilities and autism in long-stay hospitals that have been hospitalized for about more than 2 years in hospital care. This includes 350 LD patients, that's learning disability patients, that are admitted for more than 10 years. So this just highlights the need to proactively manage hospital admission. So in our study, we tried to see how we could incorporate more machine learning models to help predict a patient's duration of stay in hospital. So this would help to manage hospital resource allocation. So to avoid abnormal discharge of patients, it's possible to look at the patient's admission within the first 24 hours, as well as other historical data for that patient, and have a prediction of how long this patient might stay in the hospital to help plan resource allocation for the patient. So with the planning for this prediction, this is the extraction criterion. So once we've identified patients within Wales cohort and that are registered with the GP, identified as having learning disabilities, then we extract all the hospitalization data and the GP records data from birth for that patient. So this will help us to track certain trajectories of their conditions up until the time of their admission. So we use this information as well as other information as well for, we look at the conditions that were treated in the past 3 years, in the past 1 year. We try to use this in collaboration with the recent admission data to predict how long this patient might stay. But one thing we consider for predicting hospital stay, making a continuous time kind of prediction for an individual might be very difficult because the individuals are different and we will need more information. So what we did, we reduced this prediction to just a binary level of prediction. So we consider the average length of stay for all patients using the admission data we have. Then you use this average value as a threshold for binary prediction. So this machine learning models will predict if a patient will stay less than 4 days or more than or equals to 4 days in that current hospital admission. So we compared a couple of models, about 8 models, and the random forest model gave a good performance. We looked at a lot of variables, the BMI of the patient, smoking history, alcohol, physical activity, autism, records of admission from previous year and previous 3 years, looked at the number of conditions the patient is also treated in that current admission as well. So with the random forest behaving better, we also try to address, so for transparency, especially when dealing with health records, using machine learning for health records, we have to be very transparent about how these models behave across sensitive groups. So with the performance of this model for the male and female, there's a false negative rate, which is pretty low, and a false positive rate and balance accuracy, which we considered as a major metrics. But we try to observe how it behaves across ethnic groups. From this observation, if you see from the table here, we see that as much as the overall performance shows a given value, we see that value is not the same for the different groups. We see in this case that the white group, for instance, has a performance that is much close to the overall performance. And this has to do with the distribution of ethnic groups for patients in Wales. So the admissions, I hadn't mentioned initially, so the admission records for patients in Wales with learning disabilities is about 80% from the whites, and the unknown is a second, which is about 17% for both male and females. So with the other minorities are about less than 0.3%. So the representation of this ethnic groups in the data might not be sufficient to make an unbiased prediction. I could put it in that sense. So what we try to do is to address bias mitigation, to look at bias mitigation algorithms that could help reduce the discrepancies in the different performances. So just a brief explanation of what I mean by the false negative rate and false positive rate. So the false negative rate looks at the cases where the machine learning model predicts that a patient should be discharged much earlier, like maybe less than 4 days, whereas the patient needed to stay longer in the hospital. The false positive rate talks about cases where the machine learning predicts the patient should stay longer in hospital, whereas the patient doesn't need to stay that long, could be discharged much earlier. So looking at the three, we looked at the two bias mitigation algorithms. One is a threshold optimizer, and the other is the exponentiated gradient. So just to see how it behaves across the males, the idea is to reduce the performance range. So the performance range is just from the previous chart, we're trying to reduce the difference between the maximum value per metric and the minimum value. To a perfect model would be one that has the same value for all ethnic groups. So for this model, we saw that the threshold optimizer worked very well in reducing the differences for the false positive rate and for the balanced accuracy value. The exponentiated gradient worked better in reducing the false negative rates for the male cohort. For the female, on the other hand, it was a bit, I think the models didn't work very well with the female cohort, but with the false negative rate, the threshold optimizer was able to reduce. But in the false positive rate and the balanced accuracy, the exponentiated gradient and the unmitigated model, that's the random forest model without any mitigation, almost had the same. So there was not much impact with the bias mitigation algorithms. So just in summary, for hospitalization data, we looked at the health records, tried to examine the primary conditions for admission, looked at the most commonly treated conditions as well in hospitals between 2011 and 2021. We also looked at long stays, tried to predict the length of hospital stay using data up until the first 24 hours of admission. And we addressed two bias mitigation algorithms. And just to state, this example I've given it was used for the ethnic group, but it can also be applied for other kinds of sensitive groups. For the socioeconomic indexes, it could be applied for gender, it could be applied for age as well. It could also be applied, we could have a variable that combines multiple sensitive features, and which we could apply a bias mitigation for the combination of sensitive features as well. In another project we were doing, we also looked at identification of clusters of long-term conditions. So that has been mentioned in previous talks now from today. The idea of clustering for long-term conditions has been applied in different research, been applied in cancer studies, psoriasis, diabetes, heart diseases. So the idea is to classify patients based on the distribution of their conditions, and this could help to tailor personalized treatments for each individual. It could also help to predict health outcomes and to help to allocate healthcare resources effectively. One thing we observed from our survey is that there's limited clustering research that has been applied to analyze the co-occurrence of multiple long-term conditions for patients with learning disabilities. So seeing how much this is a disadvantaged cohort, we try as much as possible to employ ways in which we can optimize the healthcare and have personalized medicine, I put in that form, for individuals. So once we've identified a cluster, we can have a new individual with our machine learning model. We could predict what cluster this patient belongs to. Within that cluster, identify possible trajectories for that patient, taking into consideration their current trajectory. We could look at the disease progression and also study other factors like the mortality rate, the hospitalization for the patient as well. So in the study we've done currently, we looked at the cell data separated this analysis for male and females, because there are some conditions that are related to just females, such as the perimenopausal conditions, dysmenorrhea, and the rest of them. So instead of having a combined analysis, we analyzed them separately for the males and the females. We applied a couple of machine learning algorithms, and one primary concern when having to deal with clusters for conditions is identification of the optimal number of clusters, because it's an unsupervised learning approach. So we used a couple of integrated approaches to identify the optimal number of clusters for the algorithms. We used the average silhouette with the Bayesian information criterion, sum of squared errors, and what we observed when analyzing all different algorithms was the optimal clusters was between 3 to 4 clusters. So the best performing models was the Gaussian mixture model for the males with 3 clusters and the 3-cluster Birch for the females. So just looking at a brief introduction of the clusters that were identified for the male cohort, we had 3 clusters. So the first cluster was characterized by high reflux and a medium probability of mental illness conditions. The second cluster had a higher probability of cardiovascular and respiratory conditions. And the third, all the conditions were less than 50% in the probability of occurrence. So we classify this as a relatively healthy condition compared to the other clusters. So here's just the percentages of those conditions. Heart failure, 56%, kidney disease, 41%, chronic airway disease, 37%, that's for cluster 2. And the cluster 3, which is relatively healthy, still has a higher or moderate probability of mental illness and epilepsy. For the male clusters, there's also the first cluster is relatively healthy compared to the others, and that has the highest number of patients within its cluster. Still has the highest percentage of epilepsy. The second was with high reflux, mental pain, mental health conditions, pain conditions, respiratory conditions. So here's just the percentages of those conditions. And for the third, they had the highest probability of cardiac arrhythmias, chronic kidney disease, heart failure, thyroid disorders, anemia, and the rest is shown on the screen. So, like I mentioned earlier, what we plan to do with these identified clusters is to look deeper into the risk factors that are common amongst the individual clusters. We also consider medications, adults with medications, physical activity of these patients, the BMI, and other socio-demographic factors like age. So what we anticipate for the healthy clusters is most of those patients will be much younger compared to patients in the other clusters, because as we've seen from analysis that the multiple long-term condition increases with age for the cohort that we are looking at. So the idea of this is, after we've identified this, we also look at multiple long-term trajectories. So similar to talks that have been given previously. So we look at the possible trajectories. There's another approach that we're also looking at, that my colleague Rania is working on that, which we first identify the trajectories and then we create a cluster of trajectories. But this is a kind of a reverse analysis where we identify the clusters first. Then for the dominant clusters, we also identify trajectories in this. So in conclusion, what we're trying to do is we provide ways to give healthcare providers an idea about disease progression for patients. So given a patient's profile, we can identify trajectories closer to their profile over time, address premature and avoidable mortalities. So this will help also the care providers to have more awareness, especially those who cater for adults with learning disabilities, maybe the guardians or parents. They can have more understanding of the nature of trajectories and the clusters, create models to have a coordinated care, so to improve the quality of life and also reduce avoidable hospitalizations and excessive long length of stay in hospital. So this is the end of the presentation, but I'd just like to say a big thank you to those who have taken part in this project. So the Decode project is made up of a couple of work packages who address different aspects of this work. There's the data preparation cleaning, there's the AI aspect, there's also the PPIE involvement, and as well as the professional advisory panel that we liaise with continually all through this project. So thank you for this presentation.